Hello dear students. Today we are going to discuss a clinical vignette on hypertrophic cardiomyopathy. A 21-year-old male college basketball player is brought to the emergency department after experiencing a syncopal episode during a rigorous practice session. He reports feeling momentarily lightheaded and short of breath before losing consciousness. But he recovered spontaneously within a minute. He denies chest pain, palpitation, or illicit drug use. His family history is significant for a paternal uncle who died suddenly at the age of 24 while jogging. So, from this clinical history, the first clue is his young age and he is fit, otherwise, he is a basketball player and he has syncopal attack after the rigorous practice session. Second clue, his positive family history of sudden death in a young relative during exercise, which strongly suggests inherited cardiac disorder. And there is no history of chest pain, palpitation, or any drug use, so it is less likely that he is having myocardial infarction. On physical examination, his blood pressure is 115 by 70 millimeters of mercury and heart rate is 68. Of chest reveals a sustained and displaced left ventricular apical impulse. Auscultation demonstrates a harsh decrescendo systolic murmur, heard best at the left lower sternal border. The murmur does not radiate to the carotids. This is very important because the murmurs of hypertrophic cardiomyopathy does not radiate to the carotids, and these murmurs are produced due to the dynamic outflow obstruction of the left ventricular outflow tract and produce the crescendo-decrescendo type of systolic murmur during the systole, and this differentiates it from the murmur of the aortic stenosis which radiate to the carotids. An electrocardiogram shows left ventricular hypertrophy, features of left ventricular hypertrophy with deep narrow Q waves in the inferior and lateral leads. So in this ECG we can see in the lead 1, in the lead AVL, in the lead V5 and V6 we can see the Q wave, large Q waves. Q waves are normally produced due to the depolarization of vector from the left to the right in the septum. But when this depolarization vector enlarges due to the hypertrophy of the septum in the hypertrophic cardiomyopathy, these waves become much larger and become pathological. A pathological Q wave has a size more than two small boxes, that is more than 2 millimeter in the y-axis. Left ventricular hypertrophy can be defined can be defined with the help of Sokolow-Leon voltage criteria. This criteria states that the S wave in the V1 and plus the R wave, length of R wave in the V5 or V6, whichever is taller, is more than or equal to 35 millimeter, then it suggests the left ventricular hypertrophy. We can count the number of large boxes: 1, 2, 3, 4, 5. 5 boxes here, and 1, 2, 2 boxes are here. So 5 plus 2 equals to 7 boxes. 7 into 5 is equals to 35. Approximately 35 millimeter is there. So it favors the left ventricular hypertrophy. The 2D echo shows the left ventricular wall thickness of 17 millimeter. In HCM criteria, to define a hypertrophy equal to or more than 15 millimeter, and asymmetrical septal hypertrophy, that means the septum is enlarged, mainly the septum is enlarged as compared to the posterior wall. Posterior wall is less enlarged as compared to the septum, and this ratio, the ratio of the thickness of septal wall thickness upon the posterior wall thickness is more than 1.3. So it defines the HCM. Another criteria is presence of systolic anterior motion of mitral valve during the systolic contraction, and another criteria is the presence of dynamic left ventricular outflow tract obstruction. This making a gradient of more than 35 or equal to 35 millimeter of mercury, pressure gradient of more than 35 millimeter of mercury, the left ventricular outflow tract. In our patient, we have this gradient of 43 millimeter of mercury, which favors the diagnosis of HCM. Now this is the endomyocardial biopsy of his uncle who died while jogging, and it showed that the presence of myocyte hypertrophy with myocyte disarray, abnormally arranged myocytes. Normally the myocytes arranged parallelly to each other, and in this case the myocytes arranged haphazardly. These haphazardly arranged myocytes are hypertrophied and have large boxcar or square-shaped nuclei with interstitial fibrosis, and the intramural coronary artery can show dysplasia or thickening. Now come to the MCQs. Which of the following bedside maneuver would most likely decrease the intensity of this patient's murmur? In HOCM or hypertrophic obstructive cardiomyopathy, the murmur depends on the degree of dynamic left ventricular outflow obstruction. Anything that makes the left ventricular cavity smaller will bring the hypertrophied septum and anterior mitral leaflet closer together, and this worsens the SAM and increases the outflow obstruction and makes the murmur louder. So anything that can increase the afterload or increase the ventricular volume tends to reduce the obstruction and makes the murmur softer. Option A, Valsalva maneuver. It is incorrect. During the strain phase of Valsalva, venous return decreases. This decreases the preload and makes the left ventricular cavity smaller. In HOCM, a smaller left ventricular cavity worsens the outflow tract obstruction, and therefore Valsalva makes the HOCM murmur louder, not softer. Option B, abrupt standing from squatting. It is also incorrect. Standing causes sudden decrease in the venous return and it reduces the preload. Again, this makes the left ventricular cavity smaller and worsens the systolic anterior motion of the mitral valve. Therefore, abrupt standing increases the intensity of murmur. Option C, sustained hand grip. Sustained hand grip increase the systemic vascular resistance and therefore increase the afterload. So sustained hand grip increase the afterload, and this increase in the afterload causes the slowing of left ventricular ejection, and it reduces the dynamic left ventricular outflow obstruction. Because the obstruction decreases, the murmur becomes softer. So this option is correct. Option C is correct. Option D, inhalation of amyl nitrite, is incorrect. Amyl nitrite is a vasodilator. It reduces afterload, allowing the more rapid left ventricular ejection. In HOCM, faster ejection and reduced afterload worsen the dynamic obstruction. Therefore, amyl nitrite increases the murmur. Sublingual, option E, sublingual nitroglycerin. It is also incorrect. Nitroglycerin causes venodilation and decreases the preload. A lower preload reduces the left ventricular cavity size, worsens the SAM, and increases LVOT obstruction. This is why nitrates can precipitate hypotension or syncope in obstructive HCM. So, from this slide, what we have learned in HOCM, Valsalva and standing makes the murmur louder, while squatting and hand grip makes the murmur softer. Now come to the next question. The structural abnormality primarily responsible for the murmur and the patient's exertional syncope involves which of the following mechanisms? Now come to the next question. The structural abnormality primarily responsible for the murmur and the patient's exertional syncope involves which of the following mechanisms? The primary mechanism of murmur in HOCM is dynamic outflow obstruction of the left ventricular outflow tract. What makes the left ventricular outflow tract? Inferiorly, it has the left ventricular cavity. Superiorly, it has the opening of the aortic wall, and posteriorly, it has anterior leaflet of mitral valve, and anteriorly it has the interventricular septum. So anteriorly is interventricular septum, posteriorly mitral valve, superiorly the aortic wall, and inferiorly the left ventricle itself. So in cases of HOCM, the basic lesion is obstruction, and this obstruction is a dynamic obstruction which increases during the systolic contraction of the left ventricle, during which the mitral leaflet comes more anteriorly, and causes the narrowing of the outflow tract, and this creates a dynamic obstruction which produces a crescendo-decrescendo murmur. During exercise, increased contractility and reduced filling time worsen the obstruction, which can reduce cardiac output and cause syncope. Now let's see the options. Option A, calcific degeneration of the aortic valve leaflet. It is incorrect. This type of degenerative changes in the aortic wall causes aortic stenosis, which usually seen in older patients. And aortic stenosis causes crescendo-decrescendo systolic murmur that is usually heard at the right upper sternal border, and it radiates to the carotids. This patient is young athletic patient and has a positive family history of sudden death, and the murmur of this patient heard best at the left lower sternal border without carotid radiation, favoring the HOCM. So this option is incorrect. Option B, systolic anterior motion of the mitral valve, is correct. Option C, congenital fusion of the aortic valve commissures. This is incorrect. This would result in the um, congenital bicuspid aortic stenosis, and it produced the fixed valvular obstruction, not the dynamic obstruction, and the murmur would more likely radiate to the carotids. Option D, fixed fibromuscular subaortic membrane, is incorrect. A subaortic membrane causes fixed subaortic stenosis, and in contrast, the HOCM causes dynamic obstruction that changes with preload and afterload. Option E, prolapse of the mitral valve into the left atrium. It is also incorrect. Mitral valve prolapse causes mid-systolic clicks and late systolic murmur, and usually heard best at the apex, and it does not explain the dynamic left ventricular outflow tract obstruction as seen in this case. So HOCM obstruction is a dynamic obstruction, and the key mechanism is SAM, or systolic anterior motion of the mitral valve against the hypertrophied septum. Come to the next question. What is the most common genetic basis of this patient's condition? Hypertrophic cardiomyopathy is most commonly an autosomal dominant disease caused by mutation in the genes which encode the sarcomeric proteins, and most important among them is MYH7 and MYBPC3. MYH7 encodes the beta myosin heavy chain, and MYBPC3 encodes the binding protein C. So these are the two most important genes which causes HOCM. These mutations cause abnormal force generation, impaired relaxation, and results in the myocyte hypertrophy and myocyte disarray. Let's see the options one by one. Option A, autosomal dominant mutation in the fibrillin 1 is incorrect. Fibrillin 1 mutation causes Marfan syndrome, and Marfan syndrome is associated with aortic root dilatation, aortic dissection, lens dislocation, and mitral valve prolapse, not with HOCM. Option B, or autosomal recessive mutation in CFTR, is incorrect. CFTR mutations causes cystic fibrosis, which is an autosomal recessive disorder of chloride channel dysfunction, and it results in a pulmonary disease, pancreatic insufficiency, and infertility in males, with and also the recurrent infections. It does not result in HOCM. Option C, X-linked recessive mutation in dystrophin, is incorrect. Dystrophin mutation causes Duchenne and Becker muscular dystrophy. These are not associated with HOCM. Option D, autosomal dominant mutation in the sarcomeric protein, is correct answer. Option E, mitochondrial DNA mutation affecting the oxidative phosphorylation, is incorrect. And these mutations can cause cardiomyopathy, but these types of mutations are not typically associated with HOCM. Now come to the next question. Based on the provided histopathological image and the clinical presentation, which of the following is most likely underlying cause of the deep Q waves seen in this patient's ECG? In HCM, the deep narrow Q waves are often called pseudo-infarction Q waves or dagger-like Q waves. They are not caused by coronary occlusion or any previous MI. They occur because the septum is so massively enlarged so massively hypertrophied that it alters the normal current pattern, and this results in the large vector from left to the right, and this large vector presents as more negative Q wave in inferior and lateral leads. So the option is B option is correct. Extreme localized hypertrophy of interventricular septum. This produces the deep Q waves. And other options, previous silent MI is incorrect. MI can produce pathological Q waves, but these Q waves are broader, not narrower as seen in HCM. That means they have duration of more than 40 milliseconds. Option C, infiltrative deposition of misfolded amyloid protein. Cardiac amyloidosis causes the low voltage, produce the low voltage ECG. And the cardiomyopathy occurs in amyloidosis is of restricted type with diastolic dysfunction, and it affects the old age people and can be seen in malignancies like uh, myeloma or amyloidosis, systemic amyloidosis. Cardiac right ventricular pressure overload. Option D. Option D, chronic right ventricular pressure overload is incorrect. Right ventricular pressure overload may cause the right axis deviation, right ventricular hypertrophy, and strain patterns. It does not classically cause deep narrow Q waves in inferior and lateral leads. Option E, diffuse myocardial fibrosis replacing infarcted tissue is incorrect. Fibrosis can occur in HCM and may contribute to arrhythmia risk. But the classic deep narrow Q wave in HCM are primarily due to the abnormal septal hypertrophy. Option E, diffuse myocardial fibrosis replacing the infarcted tissue. It occurs post myocardial infarction. However, the fibrosis is seen in HCM also, but it is not the cause of deep Q waves as seen in this case. Now come to the next question. Which of the following medications is strictly contraindicated in the management of this patient's condition because it would worsen his primary pathophysiology? The primary pathophysiology in obstructive HCM is dynamic left ventricular outflow tract obstruction. Drugs that reduce preload or afterload can worsen this obstruction and causes the increase in the symptoms of HCM. Nitrates reduce the preload by venodilation and may also reduce afterload. This decreases the left ventricular cavity size, worsen the SAM, increase LVOT obstruction, and this can precipitate hypotension or syncope. So correct answer would be the C, isosorbide dinitrate. Other options, metoprolol. Metoprolol is a beta blocker and it is the first line drug in the symptomatic obstructive HCM. It is the drug of choice for the treatment of HCM, and it acts by reducing the heart rate and contractility, thus increase the diastolic filling time, which increases the left ventricular cavity size and reduce the LVOT gradient. Option B, verapamil. Verapamil is non-DHP calcium channel blocker. It can used in selected patients sometimes because it reduces contractility and improves diastolic filling. However, it must be given carefully in patients with the severe obstruction and hypotension or advanced heart failure. Option D, amiodarone. Amiodarone may be used in selected HCM patients for arrhythmias. Option E, disopyramide. Disopyramide is incorrect option. Disopyramide has negative inotropic action and can reduce LVOT obstruction, so it may be used in symptomatic HCM patients with beta blockers or calcium channel blockers. Now, what are the take-home messages? HCM classically present in young athlete or fit patients who have history of syncope during exertion, and there may be history of positive family history of sudden cardiac death. Harsh systolic murmur of crescendo-decrescendo type can be heard at the left lateral sternal border. Murmur increase with Valsalva or standing and decrease with squatting and hand grip. Pathophysiology is dynamic left ventricular outflow obstruction with uh, due to the systolic anterior motion of the mitral wall. Histology hallmark is extreme dysarray of myofibers with myocyte hypertrophy. Gold standard for the diagnosis is cardiac MRI. And the pharmacology trap is very important. Do not give nitrates or vasodilators in obstructive HCM because they can worsen the obstruction. The main treatment principle is to reduce contractility and improve filling using the negative inotropes. With newer disease-specific options include the cardiac myosin inhibitors like mevacem-10 and efficam-10. So this is all for today. Thank you.